Okay, I think we're going to go ahead and get started. We've got a lot of people still coming on. I want to welcome everybody to our second session of the Brain 101 mini medical school. For those of you that were on for the first session, I think it went great, and we're really looking forward to this second installment. Again, to introduce your hosts for the Brain 101 series is Tammy Lack. Tammy is the head of strategic development for the Department of Neurosurgery, also the executive director of the Neuroscience Innovation Initiative, and myself, Kevin Lillehei. I'm chair of the Department of Neurosurgery here at the university. So the Brain 101 is sponsored obviously by the University of Colorado, but it's also sponsored by the Neuroscience Innovation Initiative. I want to say just a little bit about the initiative. This is a program that we started about 2 to 3 years ago, and really it was to promote the integration, collaboration, and communication of all the neuroscience groups that are working not only on our campus here, but the Boulder campus and throughout the state, really to promote the neurosciences, both clinically and from a research standpoint. Obviously, our goal is to ultimately develop a comprehensive neuroscience institute. So moving along, this is, as you said, this is our second installment of 6. And today we're going to focus on stroke and traumatic brain injury. For those of you that missed the first session, Tammy has sent out, and she will, if you contact her, send it to you. We have recordings of all of these sessions. The recording for the first session on the brain anatomy was terrific. And if you didn't get it, contact Tammy, and she can get it to you. On the bottom, because we have so many people on the Zoom, we want to allow about 10 minutes at the end of the talks for people to ask questions. And the way to ask questions is to go down to the bottom of your Zoom, click on the chat box, and anytime from now on, you can put questions into the chat box, and Tammy will be looking at those, and then at the end, she will bring up those questions and answer as many as we can. The questions that we can't answer, we're able to then send out an email to everybody to the answer to those questions. So, kind of to move into our main event, the topic today is Introduction to Stroke and Traumatic Brain Injury. We've got 3 great speakers with us. For stroke, it's going to be a kind of a tag team of Sharon Poisson and Christopher Roark. And then Dr. Delia Bakeman is going to talk to us about traumatic brain injury. Just as a little bit of introduction, I'm going to introduce all 3 speakers initially, and then we'll move through the talk. So Sharon Poisson, Dr. Poisson is professor in the Department of Neurology. She's a graduate of Indiana University School of Medicine, did a residency at the University of Michigan, and then a fellowship in vascular neurology at the University of California, San Francisco. She's now a neurohospitalist at the University Hospital and co-director of the Comprehensive Stroke Center here at Anschutz. Dr. Roark is an associate professor of neurosurgery, got his MD degree from the University of Kansas, did his neurosurgery residency at the University of Minnesota, and then did a fellowship in neurovascular surgery at the University of Michigan, joined our department and has really helped develop our interventional neurosurgery service for both stroke as well as treatment of aneurysms and AVMs. And then finally, Delia Bakeman. Delia is an assistant professor in behavioral neurology in the Department of Neurology. She's dual trained, both in neurology and psychiatry, did her medical school and her residency training at the University of Massachusetts in Worcester. I think I pronounced that right, Worcester, Massachusetts. She's a Colorado native and actually graduated from the University of Boulder. And her interests are around neurorehabilitation of traumatic brain injury, stroke, encephalitis, and neurodegenerative disorders. And her research is centered around community access to care for traumatic brain injury patients of all socioeconomic backgrounds. So with that, I'm going to turn the share over to Dr. Poisson to start. Sharon, you're muted.
There we go. Sorry, I couldn't find the unmute button, but we got it. Thank you, Dr. Lillehei, for that kind introduction. I'm going to start by talking all about different types of strokes, what the causes of strokes are, and how we treat and prevent strokes. All right, so this is our agenda. I won't read all the questions to you, kind of covering the things we already talked about there. So I'm going to start by just telling you a little bit about what a stroke is. So stroke is really an umbrella term that I think is often misinterpreted by people, but a stroke is basically any damage to the brain that's caused by a lack of blood flow or extra blood flow in the brain because of damage to a blood vessel or clogging up of a blood vessel. Most strokes are what we call ischemic strokes. So on the left side of the screen, you can see ischemic strokes are strokes caused by a blood clot that clogs up an artery in the brain and cuts off blood supply to that part of the brain. The other 15% of strokes are called hemorrhagic strokes or bleeding strokes. These are caused by a ruptured blood vessel and blood that goes into or around the brain. We'll talk a little bit more about those things. So ischemic stroke, as I mentioned, is the most common kind of stroke. It can be caused from a clot that comes from another place in the body, like a clot coming from the heart. It can come from a plaque that's built up in an artery from atherosclerosis, and sometimes it can be caused by a problem directly in a blood vessel that's in the brain. Strokes can have different symptoms depending on which part of the brain is affected, and we'll talk a little bit more about the symptoms of stroke in a minute. These are images of the brain. On your left side of the screen, you can see this is a CT scan or a CAT scan, some people call it. And on the right side is an MRI scan. Both of these are showing large areas of stroke in the right side of the brain. So I think you'll remember from Dr. Ojeman's talk last week that this is what we call an axial slice of the brain. This is the front of the head where my pointer is, back of the head, right and left. And what you can see is on the right side of the brain here, there's a big dark wedge on the CT scan. That's how an ischemic stroke looks after it's completed. This is a pretty large stroke that also has some swelling in the brain. You can see sort of the midline of the brain is shifted over to the left side. On the right side of the screen is one of the sequences from an MRI scan, and you can see this bright white kind of wedge. That is similarly how an ischemic stroke looks on an MRI when we do it early on. I'm going to mention briefly transient ischemic attacks, or TIA here. TIA is often called mini strokes by people in the community. I don't love the term mini stroke because that makes it sound like it's no big deal. I actually like the term temporary stroke better. A TIA is really a stroke in progress. So an ischemic stroke, similar to an ischemic stroke, it's caused by a clogged up blood vessel that cuts off blood supply to part of the brain for a period of time. And then the blood clot breaks up and moves on. And so blood flow comes back to the brain before there's any actual permanent damage to the brain. This is important. It's great that there's no damage to the brain that happens, but it's important because we know that it's actually a warning sign that somebody's at a high risk of going on to have a stroke. Most TIAs last under 5 minutes, so these can often feel like no big deal because they go away quickly, but we know that up to 40% of people who have a TIA will go on to have a stroke, and the highest risk of that stroke is really in the first weeks after the TIA happens. The second type of stroke, which we talked about, is about 15% of strokes is a hemorrhagic stroke or a bleeding stroke. On the left side of the screen here, you see this, this is the CT scan again. You see this big bright white area on the CT scan. This is a hemorrhagic stroke called an intracerebral hemorrhage, meaning bleeding that happens directly into the brain tissue. And on the right side of the screen, you can see there are these areas. These are also CT scans. There's these bright areas that are sort of surrounding the different parts of the brain and bright areas that are in the folds of the brain or the sulci. This is a subarachnoid hemorrhage, which is a type of hemorrhagic stroke. Most of the time, subarachnoid hemorrhage is caused by aneurisms, and I'm going to let Dr. Roark talk a lot more about that later on. So it's important for us to know about stroke because stroke is really common. So stroke is the #1 cause of disability among adults in the United States, and it's the 5th leading cause of death among adults in the US. And this is actually great. When I started my career as a stroke neurologist, it was the 3rd leading cause of death, and we've gotten much better at treating and preventing strokes. And so it's actually, we've made some progress in where it lands on that scale of causes of death. Almost 800,000 people each year have a stroke in the US. And so that means in the hour that you're watching this lecture, about 90 people in the US will have a stroke. So really common, and most people know someone who's had a stroke or who has a family member who's had a stroke. Strokes can happen to anyone. I do a young adult stroke clinic, so we certainly see strokes in young people, but the most common time that we see strokes is age 55 and older, and especially so about 3/4 of strokes actually happen in people over the age of 65. Strokes vary by the region of the country, and you can see this map over here on the right side. The dark purples are areas where there's a lot of strokes. Right here is Colorado, and you can see we actually do pretty well. We have a much lower rate of stroke than many states in the US, although even within Colorado, there are regions where we see higher rates of stroke. Stroke incidence, so the risk of stroke increases with age. It also differs between men and women and differs by race. So some of the risk factors for stroke, we don't know how to control yet. So age, I said, is a risk factor. This is, we haven't quite found the fountain of youth yet. We're working on it, but we don't know how to treat that risk factor yet. Things like race, genetics, having had a prior stroke, those are things that are what we call non-modifiable risk factors. On the right side of the screen, you can see some of the common modifiable risk factors. These are the ones where we have something we can do to intervene and try to lower the risk of stroke. Hypertension is the #1 most important modifiable risk factor for stroke. We know treating high blood pressure, even bringing blood pressure down just a little bit, makes a real difference in stroke risk. Other modifiable risk factors are here: diabetes, smoking, high cholesterol, irregular heart rhythm like atrial fibrillation, and then things like obesity, poor nutrition, and lack of exercise. The American Heart Association released this Life's Essential 8, and these are really measures to help improve cardiovascular health. And when they say cardiovascular health, we lump stroke in with cardiovascular health. The same types of diseases that cause problems in the blood vessels in the heart cause problems in the blood vessels in the brain. And so these are kind of 8 simple things that can be done to try to lower the risk of heart disease, stroke, and other health problems. Dr. Ojeman talked a lot to you about different areas of the brain and what types of functions they have. And this is just a reminder that the brain's a pretty complex organ, and there are lots of different functions that live in different parts of the brain. So the tricky thing about a stroke is that depending on where that stroke is in the brain, the symptoms of stroke can look very different. The way that we try to teach the symptoms of stroke in order to make it easy to recognize is using this mnemonic, be fast. So BFAST doesn't cover all of the possible symptoms of stroke, but it covers the most common way that stroke starts. So BFAST stands for balance. Balance meaning sudden onset of trouble walking, trouble standing up straight. E is for eyes, so sudden change in vision. That can be either a loss of vision or double vision. F is for face, sudden onset of droopiness on one side of the face. A is for arm, sudden weakness in one arm. Can be in the leg too, but the arm is the more common place we see stroke symptoms. The S is for speech, meaning a sudden change in speech, trouble getting the right words to come out, or suddenly really slurred speech. And then the T is a reminder that time is really critical. And if somebody somebody you're around, or if you start having symptoms of stroke, the important thing to do is call 911 and get to treatment quickly. We know that quickly recognizing stroke and starting treatment early makes a big difference in how well people do in the long run after stroke. So time is brain is kind of the classic phrase used by stroke neurologists. We know that for every minute the brain isn't getting blood flow, about 2 million brain cells die. And so even just a delay of 30 minutes in getting treated for stroke leads to about a 10% worse functional outcome at 3 months. Regardless of how we treat the stroke, so generally if we can open up the blood vessel, it doesn't matter how you do that. We know that earlier you do it, the more likely you are to make a good recovery. And so it's really critical to recognize stroke and get to treatment quickly. So for ischemic stroke, the way we treat it is by opening up the blood vessels. So there's something clogging up the blood vessel, we need to open it up. We have clot busting medicines that can help do this. Sometimes people will call this TPA or TNK. We have a pretty short window of time for those medicines to work. So only 4.5 hours from the time somebody was last 100% normal, we have 4.5 hours to get that medicine started. So you can imagine if you take a nap to see if the symptoms get better, you lose that time window. The other major way that we try to open up blood vessels is by using a device to try to pull the clot out from inside the vessel. And I'm going to let Dr. Roark tell you more about that. This is actually a graphic that shows all of the different interactions between different hospital workers and a patient with stroke symptoms. So quickly in the emergency room, you have about 18 to 20 people who are in some way involved in the care of somebody who shows up with stroke symptoms. We like to call it controlled chaos. It looks pretty chaotic in this picture, but there is sort of a rhythm to what we do. We have a very short time window once somebody gets to the hospital to try to give them the clot busting medicine or get them to a procedure if they need it. We even now have a fancy ambulance called a mobile stroke treatment unit that is almost like bringing the emergency department to the patient as opposed to bringing the patient to the emergency department. So it's a special ambulance that has a CT scanner on board. It has a critical care nurse, a CT tech, a paramedic, and an EMT, and we can actually deliver those clot busting medicines to people on the ambulance before they come to the hospital. Once somebody is in the hospital, our first priority is to try to stop that stroke in its tracks. Next, we start looking for a reason for why the stroke happened. And then once we figure out why the stroke happened, we start medications and do procedures potentially to try to prevent another stroke from happening. And then the other piece of being in the hospital after a stroke is getting started on rehab, because we know that rehabilitation, things like physical therapy, occupational therapy, speech therapy, make a big difference in how people do in the long run. For hemorrhagic strokes, Dr. Roark will talk to you a little bit about this, but the goal of a hemorrhagic stroke treatment is to stop the bleeding. So we don't want to give clot busting medicines, we want to do the opposite. So a big piece of that is controlling blood pressure. Sometimes we can use medicines to try to stop the bleeding, and sometimes people need surgery. So just in summary, it's important for you to know that stroke is common, recognize the symptoms of stroke with BFAST, and knowing that getting treated quickly is critical. Know your risk factors and work with your primary care doctor to control those risk factors. And we already talked about life's essential aid. It's a simple way to think about it. So that's what I've got, and I'm going to let Dr. Roark take over with the next steps.
So while Dr. Roark is getting his slides, I want to remind people that to ask questions as we're going through this, go down to the chat and then just put your question in there and send it. And we'll have time at the end to answer some of these questions.
All right. Can you hear me, Dr. Lillehei?
Yep.
Okay. All right. Thank you, Dr. Poisson. So I'm Chris Roark, one of the neurosurgeons who treats stroke along with Dr. Poisson. And so since this is a format of like a neuro-focused mini med school, this is continuing neurovascular 101. So we've got objectives, just like Dr. Poisson. We're going to review the vascular supply to the brain and how variations in that contribute to diseases in the brain. And then I'm going to review some modern treatment techniques, and there will be a test at the end. I'm just kidding. Please don't sign off. Let's start with brain oxygenation. Oxygen is a big deal for the brain. And this slide kind of shows us the issue with the brain is that the brain, on average in a human, like Dr. Ocean probably mentioned, it weighs about 1,400 grams, so about 2% of the average 70-kilogram person, but it consumes 20% of oxygen consumption per minute. So it is an oxygen-hungry organ. It is very metabolically active. If you look at the oxygen consumption per 100 grams of tissue for skin, 0.2, resting muscles 1, brain's way up there. The kidney and the resting heart, they consume a little bit more oxygen per gram of body weight, but not much. And by percentage, again, the brain contributes, so it needs a lot of oxygen. It's the oxygen for the brain is not a want, it's a need. So this is the last slide that will look like this with a lot of stuff on it. But the issue here, to follow up on Dr. Poisson's points about time being brain, if you don't have glucose and oxygen available, then you can't do this thing called oxidative metabolism. And that is a whole bunch of different reactions that are going on in your body to maintain homeostasis that require oxygen. And brain function is very quickly lost if you lose its supply of oxygen. So another way to put finer points on it, in the case of global cerebral blood flow arrest, consciousness is lost within 10 seconds. And then the high demands of the brain, they actually work against us in this because they exacerbate the pathological consequences when we interrupt blood flow to the brain. So a lot of irreversible injury to brain tissue occurs within just minutes of blood flow interruption. I remember when I was a medical student, one of the things that really stuck with me was our professor in the neuroscience section said that within 4 minutes of getting a lack of oxygen, cells in the hippocampus, critical cells, start to die. And so the last bullet point here, I think, is really good. So they did a quantitative assessment of this whole time as brain concept. And to Dr. Poisson's point, in acute stroke, it's estimated that about 1.9 or 2 million neurons are lost every minute. If you look at the math, we think there's on average about 86 billion neurons in the human brain. And so you're actually losing 2% of those neurons every single minute that the brain is starved of oxygen. Blood supply. This I just thought, I've always loved this picture. This is a picture of the vasculature of the blood vessels of the brain. They've stripped away the actual brain tissue itself. That's on the left. This is obviously a drawing, but the brain also is even more prone to problems with oxygenation because of the way the blood flows to the brain. Is that a lot of the bigger vessels, they actually flow on the undersurface of the brain and then in the crevices between parts of the brain, and then they send smaller and smaller vessels into the brain. And so there are areas of the brain that are kind of getting enough blood to work, but they are not robust as far as having collaterals or extra blood flow. This is another just drawing where blood is coming from the heart. It crosses into the smaller arteries. Capillaries are where oxygen is kind of handed off and given to the cells, and then blood returns to the heart through veins. The way I explain it to a lot of patients, and I'll explain it to you, is it's this cycle. So if we start down here at the heart, the vessels that come out of the heart is the aorta, it's large. And every vessel that comes off it, it's like the branch of a tree. And so if you think about a tree going from the trunk up, every time there's a branch point, the 2 or 3 subsequent branches are smaller and smaller and smaller. That's what the arteries are doing in the brain, and also, to be fair, in every organ in the body. So that's what happens. It goes up to the brain, and then the oxygen exchange occurs. So we give the oxygen to the brain cells so they can do what they do, and then blood has to get back to the heart. And I like to tell patients it's like the reverse process. So we are starting to come back, but blood vessels are getting larger and larger as they come together. This is an angiogram. So I'm trained to do angiograms, and so we put catheters directly in the blood vessels in the neck, and we shoot dye into those catheters. We shoot contrast dye, and we take x-rays while we do it. And so what it is that the x-rays can see through your tissue. They can't see through the contrast dye. And so the contrast dye gives us a perfect cast of the blood vessels. So what you see here is these are 2 different views, standard views. The catheter tip is right there. We injected contrast into the left internal carotid artery, and it comes up and it does all of this beautiful branching, and you see it coming out. This is what we would call the arterial phase. And so again, arteries are taking blood to the brain. As they branch, they get smaller and smaller and smaller. Veins carry it back. This is the venous phase. So now what we see is that the contrast here, so there's contrast in the arteries, comes through, here are the veins. Blood is flowing from smaller veins to larger veins to these big things called sinuses that eventually flow out of the head. This is a video that just kind of, the cool thing about angiography is we get to see how the blood flow gets there, because the contrast follows the blood. So this is an injection, right internal carotid artery. This is the arterial phase coming through venous, boom, blood's gone. Only takes a few seconds. And so what's in a name here? Neurovascular surgeon, neuroendovascular surgeon. There's a lot of different names for what I do, but at the end of the day, I'm kind of a plumber for the brain and spinal cord. And so I want to talk to you a little bit mostly about what devices we do and how we fix these problems. So I would say that ischemic stroke, like Dr. Poisson focused on, it's when the pipe is clogged. And the device you're looking at on the right side of your field absolutely revolutionized stroke treatment, because this is highly effective for getting rid of clots. It's called a stent retriever. I always tell people it's like a stent on a stick. So we push this stent out into a clot, it grabs hold of the clot and then pulls it out. Okay. In the essence of time, I'm going to skip a video for now. We can go back to it if we need later. This is a picture of that angiogram. Just like I was telling you, we put contrast in the left internal carotid artery right here. And what you see here is, what's shocking is the absence. So all of this is all brain that isn't getting any blood, because there's a blood clot right there. So after we pulled the clot out, that's the same patient. So before, after, all of this tissue now has blood flow restored, whereas before it wasn't getting any blood flow. These are 2 different patients that I've done in the last 6 months. This is your basilar artery, which runs right in front of your brainstem. It's right, it's kind of right behind your palate, back of your mouth. And what you see here again is conspicuous because of what you don't see, and that'll be evident here in a minute. The basilar artery fills, and then it kind of abruptly stops, and there's nothing up here. Same thing here. The basilar artery fills to here, and then there's nothing. And this is after we pulled the clots out. So all of this now is filling that wouldn't have been filling before, and all of this is filling as well. This is just some evidence of clots that we take out at times. The one on the right, this is just a good-sized clot that we got out of somebody's middle cerebral artery. Over here, Dr. Poisson had mentioned that some people have clots that go to their brain from other organs. This is a patient who had a large clot in his heart. And I did several passes, and every time I got more and more clot out, to the point where when we did his follow-up echo the next day, he had no clot left in his heart because he had literally sent it all to his brain, and we were able to get a good amount of it out. I'm going to switch gears to hemorrhagic stroke. So this is when you have a leaky pipe, right? So you have a hole in the pipe. The device you see there is an aneurysm coil. These are very soft platinum coils that go through microcatheters, and we can treat aneurysms now, which are like bubbles off of blood vessels, from the inside. And again, these devices really revolutionize the way we treat brain aneurysms. So what you see here on the left, this is if you remember the angio I just showed you about the stroke, this is abnormal. This is a basilar apex aneurysm or a basilar tip aneurysm. For reference, like, these were one of the more difficult neurosurgical operations. Clipping these when they ruptured, this is sitting kind of at the base of the brain in the middle of the skull. It's exceptionally difficult to get there. And what you can't even see on angiography, there are really small blood vessels that are going all around this, and they go to the thalamus. There's each side of the thalamus is right here. And if you remember from Dr. Ojiman's lecture, the thalamus is exceptionally important in so many functions. And so these were exceptionally difficult to treat with open surgery, where we as neurosurgeons go in, take part of the skull off, go down, and put a clip on it. What you see on the right is that aneurysm was completely fixed from the inside of the blood vessel. So I put a catheter in this person's femoral artery in the leg. We ran the catheter and a microcatheter all the way up, put it inside the aneurysm, and deposited these coils that look like this. And so you put a coil out about the size of the aneurysm, and it's like Russian dolls. You put progressively smaller and smaller coils inside, and this aneurysm is fixed without having to open the patient's head. This is another difficult aneurysm. So right here, you see this kind of boot-shaped aneurysm. This is abnormal. These are normal blood vessels. This is abnormal, and it has this tiny little jet going into it. And then afterwards, it's hard because it's like you're trying to see what isn't there. But that's all coils packed in right there, and that aneurysm is no longer filling. We can also deal with corroded pipes to keep up the plumbing analogy. So to Dr. Poisson's point that ischemic stroke can happen because of clot coming from elsewhere, some people, where their carotid artery bifurcates in the neck, they have plaque there. And the traditional, we can use stents to try to stent that open. Now, since this is medical school, I'm going to warn you that there's some graphic images coming. The other way to fix this, which I enjoy as well, so this is the carotid endarterectomy. So the next time, I know for me, every time I go to McDonald's, I think about pictures like this, because this right here is basically a calcific atherosclerotic plaque. So when we say you have atherosclerosis or hardening of the arteries, this is an artery that we have clamped off on both ends. This is your common carotid artery, internal, external. We've clamped it off at both ends, cut the thing open, and then we have this big plaque that is a perfect cast of the vessel that we take out. I'm sorry I don't have a more magged up picture, but this is what the artery looks like after we've cleaned it up and then before we sew it up. So that's much more invasive, obviously, than a stent. And I enjoy doing this procedure. It's a lot of fun. Patients enjoy the stent a lot more. This is an example of a stent. This patient had a previous carotid stent, had more stenosis. So you see before, see how narrow the vessel, this is the carotid artery, gets. And then after, we put another stent in, and that vessel has nearly normal caliber. This is another one where a vessel was torn, had this very, very small channel through it before, put a stent in, caliber is basically normal. I'll end on the latest frontier, what we're doing for brain aneurysms. This is called flow diversion. So what you see here is a very special type of stent that we can place across the neck of an aneurysm. So this is an aneurysm. Traditionally, I say traditionally, in the last few years, we would put a microcatheter in just like I showed you and put coils in. But now for some aneurysms, we can put these special stents across the base where we don't even have to go into the aneurysm with coils. And over time, what happens is that stent, it's like a very tight mesh screen door. So blood can get out of the stent into the aneurysm. It has a little bit of trouble getting back in. And when blood sits still, it clots. And so the blood stays still in the aneurysm, clots off. And over time, this promotes healing and you kind of grow a new vessel lining. So this has been revolutionary for us. This is an aneurysm that would have been exceptionally difficult to treat with just coils or with surgery. And so what you see that the authors have done in this is the aneurysm right here. They put a few coils into it because we often will with big aneurysms. But the biggest thing they did is they put a flow diverting stent from here to here. And this is a follow-up angiogram 6 months later where you in essence have a normal looking vessel. So that's just a small tour of the way we fix brain aneurysms and other problems with stroke and retrieve clots these days. This is a lovely woman who I treated. She was pregnant in her second try. This is all like on the public. This was on the news. They did a news story about her, but she was losing vision when she was in her second trimester of pregnancy. This was shortly after I got here. And so we did that flow diverting stent on her because she had an aneurysm that was literally pushing up into the bottom of her optic nerve. And so we did that. Her vision came back. Several months later, she had the baby. Everything was fine. So that's us up in the mountain. So thank you very much.
Well, Chris, thank you very much. And just to kind of add something. I think people don't realize that the vessels that Dr. Roark's talking about, these are 2 to 4 millimeters in diameter. I mean, they're very, very tiny. So that stent retriever and the coils and the rest, they're kind of blown up in that picture, but they're very tiny devices.
I should mention, that's a good point. So the wires we typically use to go inside of an aneurysm, they are 0.014 inches in diameter. And the catheters we use are about 0.017. So yes, that is a good point, that those were highly magged up, but these are tiny little vessels that we're trying to navigate into.
Okay, well, thank you, Dr. Roark. So we're going to get a lecture here of traumatic brain injury 101.
All right. Well, hi, everyone. Welcome. And we're honored to have you and so excited that everyone's pumped about neuroscience. So we are going to bust through this. I would love to talk about brain injury all day long, but we will do it for 15 minutes. So I wanted to start with a great quote. We were lucky enough to have Sanjay Gupta come and present for a conference earlier this month. And he said, the brain is the most enigmatic 3 pounds in the known universe. And I liked that. So we're going to explore a little bit of the secrets underlying brain injury today. So I want to start with a video of brain injury. This is a trigger warning. This is showing somebody experiencing a traumatic brain injury on video. So this is snowboarder Kevin Pierce. This was in 2009, right before the Vancouver Olympics in 2010. He was an up-and-coming star, was kind of thought to be the next Shaun White, was really famous for what you just saw. He could get great air on his board. So he's going up, 20 feet in the air above the half pipe and the super pipe. But unfortunately, you're about to see his injury right here. So you see Kevin going in. He does this move and then he just goes straight down and is face into the super pipe. So this was from the documentary of his life, and we're going to check in on him at the end of the presentation. All right. Sorry, this one was not behaving for us earlier, so we'll just get right back into it. Okay, there we go. So brief little refresh. I know that you got a great lecture last week, but just from a brain injury perspective, a couple of things to be aware of. When we're thinking about the outer layer of the brain and what is protecting us when we have a brain injury, starting with the skull. The skull is an extremely wonderful protection from penetrating brain injury. So everybody might recognize on the right side, it's been a while, but Game of Thrones, the Mountain was pictured crushing someone's skull in his bare hands. And in fact, we know that this is actually impossible. There have been studies done, and it would actually take about 500 kilograms of force to crush the human skull. A person would have to weigh 1,100 pounds to be able to do this. And so the skull is quite protective against penetrating injuries. When we're thinking about the layers of the brain, we have the skin on the outside, we have a layer of fat, we have a layer of blood vessels that have a potential to, and nerves that have the potential to rupture or be damaged where we're talking about direct injury to the brain. We have the skull, we talked about the bone, and then we have the 3 meninges, the dura, arachnoid, and pia mater. And between the arachnoid and pia mater, we also have the cerebrospinal fluid, which can act as a shock absorber when we're discussing traumatic brain injury. So I know you got some of this last week, but just remembering again, the brain is including over 100 billion nerve cells and support cells, specifically related to brain injury. We do a lot of focus on the axon, which you can see in that right upper region here. The axon is covered in the myelin sheath, and this is how we can help transmit information from cell to cell. And the myelin sheath allows that information to be transported more quickly. And, combined, when we see these axons with their myelin sheath, they are forming essentially highways throughout the brain itself, connecting one region to another. So when we talk about traumatic brain injury, unfortunately, it's not so easy. We would love to just say, you smacked your head, you have a traumatic brain injury. So it's a lot more complex and involved than that. We now have upgraded our definitions. We're trying to get a little more detailed and inclusive for this. There is generally in all of the definitions, the idea that we have a biomechanical force that is applied to Traditionally, the head, there's now evidence that you can actually have these forces occur in the neck or other regions of the body. And as long as they are then transmitted to the brain, you can be considered to have a traumatic brain injury. We're talking about acquired traumatic brain injuries tonight, and these could be penetrating or non-penetrating. An example of a penetrating brain injury would be a bullet to the skull. An example of a non-penetrating injury would be someone who is in a car accident who has a forward and backward whiplash motion, but their head doesn't strike the dashboard or the seat behind them, but within the skull, the brain is hitting the front of the skull and the back of the skull. So that would be a non-penetrating injury. We can try to define TBI by clinical signs and symptoms. So we can think about if people are experiencing blood or skull fracture at the time of injury, we can think about loss of consciousness, about long-term symptoms like headaches, things like that. So we'll go into it a little bit more. We can also define traumatic brain injury as primary, so the injury that happens right at the time of the trauma, or secondary. So what are the later consequences over hours to days to months to years of how the brain evolves after the injury? So there are some updates kind of actively going on to better define brain injury. For tonight's purpose, we're going to stay with the classic classifications that are better known. And so brain injury can be divided into mild, moderate, or severe. Mild traumatic brain injury is commonly synonymous with concussion. In mild injury, generally when you're looking at imaging, a CAT scan is what's most often pictured at the beginning. Normally you're not seeing, again, that level of force and a concussion that would generate blood in the brain or skull fracture. Those are normally associated with more moderate or severe injuries. There is most commonly the presence of loss of consciousness. This is a shorter period of time for mild and then progressively can get longer as we get to more severe injuries. At the time of injury, it's common that people might be altered. They can be agitated, confused. They might have difficulty speaking or declaring what's going on, and that can last for brief periods to longer periods. People can get something called post-traumatic amnesia, which is a really interesting state where the brain is unable to make new day-to-day memories. An example of this, some of my severe traumatic brain injury patients, it might take them 3 months after their injury to make new memories. And so you can be talking to these people, they're awake, they're communicating with you. If you don't dive deeply, you might think that they're interpreting and understanding what's going on. But when you start getting in there and asking specific questions, how did you get here? What happened to you? What's today? What do you do for work? What are you up to? People aren't able to answer those kind of details. And a lot of these patients will describe almost an awakening that happens months later, where suddenly they do know where they are. They do know what happened to them, but that time feels like a chunk of time that was lost. In medicine, we also use the Glasgow Coma Score pretty commonly. So this is a measurement of 3 different regions. We're looking at eye-opening response. So this is normally, say somebody's had a car accident, the emergency medical team has arrived on scene, and they're looking to see, is the person spontaneously opening their eyes to speech or to pain, or just the eyes are completely shut. They're checking verbal response. So is the person oriented and responding appropriately, or are you not even hearing any sounds from them? And then they're looking at the motor response. Is the person able to follow commands with their limbs and with their head, versus that person is not moving at all? So the most severe Glasgow Coma Score that can be obtained is a 3, and then the best score would be a 15. So just some stats, and again, you just saw some of these stats about stroke. Over 2.8 million Americans are sustaining a brain injury every year, and this is not including emergency department statistics, primary care, urgent care, or you can imagine all of the people that have a head injury and don't present to the hospital or the doctor. We had almost 70,000 traumatic brain injury related deaths in 2021, and the numbers are comparable over the last few years. Very high hospital prevalence as well. We see the most common populations to have TBI. Our highest risk is an older population over 75 years old, mostly secondary to falls. We also know that men are almost 4 times at high risk for traumatic brain injury compared with women. In terms of the types of traumatic brain injuries out there, the different causes, very wide. We hear a lot on the media and television around football and concussion, but there are many sports that can be associated with traumatic brain injury: soccer, hockey, horseback riding, skiing. For motor vehicle accidents, it's not just cars. We can see motorcycles, bicycles. Unfortunately, around the Denver area, everyone's seen these great scooters, but unfortunately, I see the other side of what a scooter can look like here in Denver. Our veterans can be experiencing different types of brain injuries. We can have blast injuries, people who are paratroopers jumping out of planes and landing and having a different type of brain injury impact. People who are victims of domestic violence can have strangulation or repetitive head injuries, and then really have difficulty seeking safe treatment or care when in those situations. We see substances being highly linked to traumatic brain injury. Not only when someone is intoxicated, they're at higher risk of being involved in assault or in a fall, but there are also certain types of substances that are neurotoxic to the brain and can actually induce certain types of brain injuries as well. And then falling, we mentioned in our older population above 75, this is a higher risk, and also in our very young children, falls can be common as well. So why do humans have so many brain injuries? Why is this such an issue? So unfortunately, we evolved to get big brains, and this is a nice little comparison just of brain and neck and spine musculature of different types of animals. So you can see the whale at the bottom. We have the woodpecker, the domestic sheep, and the bighorn. But unfortunately for humans, as we've evolved with more brain, we have maintained weak neck musculature compared to the rest of the majority of the animal kingdom. So you can imagine that with this jaguar on the left, if he were to experience a traumatic brain injury, the distribution of force throughout that neck musculature would be better for him in terms of the support that he has there. Whereas Justin Bieber, if he were to experience a traumatic brain injury, that distribution of force through the neck is going to be different. And so we are basically more susceptible in the way we evolved to some of these brain injuries. And you can also see just even from some of these photos how the neck can very much shape brain injury itself and how it could be concerning based on the twisting and turning of the neck, internal rotation, how that could affect the brain as well. So brain injury can be divided into, there are many ways to talk about this, but often we discuss the primary injury. So this is the injury where the external force is applied to the brain at the time of impact. This is normally leading to our most severe and immediate symptoms. So we can get shearing of those axons that we were looking at earlier. We can get fractures to the skull and other bones within the skull. We can get contusions or bruising in the brain. And we can get traumatic axonal injury where, again, we have damage to the axons and there's deep tissue swelling in those regions. Based on basically the way the brain fits within the skull, there are particular areas of brain injury that tend to be impacted more commonly. So you can imagine all of those examples I gave earlier, football versus a car accident versus a paratrooper. You can imagine how diverse brain injury is. This is part of why it can be difficult to study, difficult to research. But in general, because of where the brain fits in that skull, we tend to really be hitting these frontal and temporal regions. And everybody is now an expert on kind of where those are and a little bit of what they do. So you can see on this graphic on the right, these are some of the regions that tend to be predominantly affected in brain injury. And you could see that mechanism through the video of that brain moving within the skull itself and the regions that it's striking. So I won't belabor this slide too much because this has already been discussed to some extent in the stroke lecture as well. But again, talking about specific regions of the brain and what they do, when we look at brain injury and some of the most common consequences we see, we definitely see difficulties with executive functioning, that ability to make complex decisions and follow multi-step commands. There's attentional difficulties. So it's almost like an induced attention deficit disorder that can occur after brain injury. We can see difficulties with memory retrieval and particular aspects of word finding with language. The insular region, where our amygdala is stored, can lead to emotional learning and conditioning issues. So a lot of patients with brain injury have personality and behavioral changes. There's often irritability. There can be post-traumatic stress disorder and difficulties with depression and mood lability and management there. For more severe injuries, you can also have damage to the brainstem, which can damage our arousal centers and lead to fluctuating consciousness and some of that traumatic amnesia we discussed earlier. There can also be secondary injuries. So again, this is after that immediate impact. We're talking over 12 hours. Some of this injury originally was thought to peak kind of in early days, but now we're seeing some of these inflammatory markers that can be elevated for months to years after brain injury. I won't go too deep into some of the details of this, but essentially we can see a lot of different changes in secondary roles to the brain. So we can see inflammation, where we have this big wave of cytokines, inflammatory chemicals that are released after the brain injury. We can have a breakdown of the barrier, the blood-brain barrier, that can lead to further inflammation. We can have infiltration of basically cytotoxic or toxic products into these cells and have tissue breakdown and other changes kind of long-term. And we're learning more and more about this over time. So I want to be thoughtful of time. This isn't a talk today about really the symptoms of what brain injury can look like, because the spectrum is so wide, but I love this slide. It's actually made by one of our own behavioral neurologists, Dave Archnegas, but it basically shows you that this is a really complicated condition that can happen. We have to think about the person who they were before the injury itself and its mechanism, and then all of the risk factors that can happen after injury. The basically graph on the right can show you all of the particular symptoms that you can see commonly in brain injury. And again, each person could be a mix of any of these things. Rehabilitation is central to traumatic brain injury, just like stroke, as was discussed before. And there are lots of fantastic resources around that. And in the state of Colorado, this is Kevin Pierce, our snowboarder, from the first video with his baby on that right-hand side. So he had really a beautiful recovery, and he does still snowboard. He's not competing, but he's been back on the slopes after his injury. This is me and a nurse in my office after we did the Pikes Peak Challenge for the Brain Injury Alliance every year. So we've got a lot of great groups in Colorado. So thank you so much.
Well, Dr. Bakeman, thank you very much. This has been great. We've got some time left and some questions. So Tammy, do you want to start out with some questions?
Yeah, we have quite a few, so I'm trying to decide which ones I should ask. Starting with the stroke folks. Why do you think the east and the southern parts of the country have more strokes?
That's a great question. I don't think we know all of the reasons. We call that area sort of in the southeast, the stroke belt of the US. And there's actually a small area that's called the buckle of the belt that has the highest incidence of stroke. We definitely see higher rates of stroke risk factors like high blood pressure and diabetes in those regions. And so that probably adds to some of it. There's also in a lot of those regions some racial diversity that probably leads to it, and more socioeconomic diversity. And those things we know increase the risk of stroke. So I don't think we know all of the reasons, but that's been pretty consistent over many years that we've seen that stroke belt.
Thank you. Can you explain the differentiation between the sudden onset of Bell's palsy versus stroke?
Another great question. So Bell's palsy is a facial droop that can happen because of an injury or inflammation to the nerve that goes to the face, called the facial nerve. And that is the nerve after it has already left the brain. So it is not actually an injury to the brain, but it's related to the nerve outside of the brain. Bell's palsy most of the time happens a little bit slower than stroke. Stroke, for the most part, is all of a sudden like 1 minute you're fine, the next minute you're not, and can cause a facial droop. In most cases, facial droops related to stroke involve mostly the lower part of the face, so a droopy mouth, and does not affect the upper part of the face. So does not affect the ability to open the eyes, to lift the eyebrows. And doesn't affect sort of the blinking of the eye, whereas Bell's palsy tends to affect both the upper and lower part of the face. So you usually will see a droopy face, but you also see somebody can't really close their eye well on that side, and they can't lift their eyebrows. It can be really challenging to tell the difference, and so it's not uncommon that I get called to the ER to see a patient with stroke symptoms, and it turns out it's Bell's palsy, which is much better than stroke. But it can be tough to know the difference.
Thank you. This one's for Dr. Roark. How fast can you do a thrombectomy?
I think my fastest time is 16 minutes from the time we punctured the femoral artery until we had the clot open. So yeah, we could, when the vessels are straight and when the clot wants to come out easily, it is a very, very fast procedure. I would say usually we're in the 20s, we're in the low 20s. So yeah, about 15, 16 minutes is the fastest so far.
Okay. To any of you, do you suspect that a vegetarian diet may reduce your risk of arterial sclerosis or ischemic stroke?
I guess I'll take that one. Sounds a little controversial. I think that certainly there are really healthy ways to eat vegetarian diets, but there are also healthy ways to eat diets that include meat. The best evidence we have for diets that lower the risk of stroke and cardiovascular disease is for a Mediterranean diet. And Mediterranean diets include high, sort of amounts of especially leafy green vegetables, a lot of whole grains, and lower fat proteins. So things like poultry and fish can be included in a healthy way in a Mediterranean diet. I think there are definitely ways to incorporate a vegetarian diet that can be very healthy and can be great for stroke and cardiovascular prevention.
This one's probably for you too, Sharon. Is quality stroke treatment widely available in both small and large hospitals?
A fantastic question. We've gotten a lot better over years at providing quick and good stroke care. It has always been, really concentrated in urban areas where you have lots of big comprehensive stroke centers. But as we've recognized how fast stroke treatment is, how critical it is, we've started to do things like called telestroke. So I do this, my colleagues and many places all over the country do, where we can actually use a computer to treat people quickly in emergency rooms across the state, in the mountains, in rural areas, and help the emergency departments deliver quick care, especially that clot busting medicine, and to make decisions about how whether a patient needs to come to a big comprehensive stroke center for things like a thrombectomy. So it's certainly, there are still disparities, still differences in how quickly stroke can be treated in more rural areas, but we've made a lot of progress over the last, I'd say, decade or so.
Great. And last question for Delia. With post-traumatic amnesia, does the patient actually know that they're having the amnesia while they're having it? Or do they just have to learn about that later on from people telling them that they had it?
Yeah, it's a great question. Normally, there's not awareness of the amnesia in that state. And so really later on, people are describing it. It really is like a lost chunk of time. Sometimes there's snippets. Sometimes people have, some specific memories that for whatever reason stay alive for them, like snippets of the hospital, or I remember this nurse, or I remember my mom coming to the bedside briefly, but really it's described as lost chunks of time. So there's not good awareness of that change. Yeah, great question.
And we just got one in for you, Delia, that says, just a comment, this person met Kevin Pierce when he came to Craig Hospital in Denver, and he was there with his TBI.
Yeah, and actually, I didn't mention it just due to time, but Kevin and his brother run a really great nonprofit called Love Your Brain that is in Colorado too, and they do a lot of work for mindfulness and yoga post brain injury. So a lot of people who have experienced brain injury or whose lives brain injury have touched, really understand how complex the healing and rehab is. So yeah, no, his great family.
Dr. Lillehei, back to you.
Yeah, so we've run out of time. We're at the end of the hour, and I really want to thank all of our speakers. I think it was a great session. Again, this is recorded, so if contact Tammy and she can get the recording, and we will attempt to answer all the questions that we didn't get to and send those out. So next week we're going to be talking about brain tumors and neuro-oncology. Same time next Tuesday, 7 o'clock. Thank you all.